Me that you can hear me normally or not, and if you can yeah, see my screen. Okay, is there anybody waiting and cannot join? If somebody has any problem in joining, please write, because it happened in a weird way today. Okay, good. So no problems, we can start our class. So here we have the following for today. We are going to speak about different pathological disorder of the kidney. So let's see. And here it goes. So speaking about the renal system, we are going to speak about the following pathology, starting with renal papillary necrosis. Speaking of renal papillary necrosis, the problem is in the papilla. So papilla is basically a finger-like projection. That's how we say it in Latin, finger-like projection. And there is basically a sloughing off of the renal papilla. The first thing you must know is, where is the renal papilla located? It's located at the tip of the pyramid of the kidney. So comes the question, where is the pyramid of the kidney located? If you take a look at the kidney, you can see that it has like these little pyramids. You have between 8 to 12 of them, and they are located here. So in this pyramid, they have this little outflow tract, this little thing. This is the papilla. Okay, so in case of renal papillary necrosis, that papilla is the thing that dies. Okay, so can someone tell me please, is that papilla a part from the medulla or the cortex of the pyramid? Excellent, it's the medulla. Can someone tell me which portion is more hypertonic of the kidney? Is it the medulla or the cortex? Which portion is more hypertonic? I mean, it has much higher osmolality in the interstitium. Okay, I noticed this, like not everybody knew this one, so that's why I asked about it actually. So if we speak about the nephron concentration of like osmolality, there is this diagram you must keep in the back of your mind, you know? So it goes something like this. If we speak about a nephron, you have the cortex and you have the medulla, yes? Notice, the deeper you go down, the higher the osmolality of the urine becomes. So 300, 400, 600, and 100, 1200. So you see, the more down you go, the higher the osmolarity. Keep in mind that this is the cortex of the medulla, and this is, sorry, the cortex of the pyramid, and this is the medulla of the pyramid. And it's even written here, cortex and medulla. Okay. So if I ask you now, which portion of the kidney is more hypertonic? You will answer medulla. Yep, good. So the next thing you must know is like renal papillary necrosis, sloughing of necrotic renal papilla, which lead to gross hematuria. So you will be able to see blood in the urine. It may be triggered by recent infection or immune stimuli. This is completely useless. The most important manifestation of it, the most important manifestation that you will take a look at and be like, oh, okay, this is renal papillary necrosis, will be the symptoms actually. So, but how the symptoms come to the patient? He will have hematuria, urine inside of, blood inside of his urine, and he will have one of these conditions. It's like this interstitial nephritis type of thing. Remember when we spoke about interstitial nephritis, I told you a lot of stuff can cause it, but you don't really care about the all of stuff because it's so many things, it's difficult to memorize. The main thing is to know the symptoms. They will have eosinophils in the urine. That's the important thing. Okay, so renal papillary necrosis. Is the problem before the kidney, in the kidney, or after the kidney? In the kidney. That's excellent. Yeah, it's in the kidney. So can you tell me, please, if the problem is in the kidney, what will happen to the BUN creatinine ratio? Yep, it will be low. Exactly. It will be reduced. Exactly. It will be low. Good. Why it's low? Is it because BUN has more absorption or less absorption in this case? Less absorption. Exactly. Good. So less absorption of which substance, please? Urea. Exactly. It's urea. Good. So you must know that this renal papillary necrosis occurs secondary to some diseases, including sickle cell disease or triad. So this is actually super important. I would like to spend like a couple of minutes about speaking about sickle cell trait and disease. Exactly. That's what I'm going to spend a couple of minutes about. So sickle cell anemia. So when you speak about sickle cell, it's a disease that is hereditary and in which the cells become looking weird. They basically, you will have sickle cells. And this happens because of a problem of some proteins inside of your RBCs. What I want to reach that, not spherocytosis, sickle cell electrophoresis. That there is something called electrophoresis. And in that electrophoresis, it goes something like this. And it goes something like this. If you take a look here, yep. It goes something like this. As you can see here in this section of the electrophoresis, I want to explain how do we do electrophoresis first, because we are going to see it so many times, so it's better to know it from now, not to have a headache with it in the future. So you have your hemoglobin A, F, S, A2, C, whatever. All of the hemoglobins you have normally. Then you do what? You put the specimen here. And then you put electricity, negative charge, positive charge. Start that electricity. When you start that electricity, they will be separated according their weight, okay? So the heavier the particle, the lowest it will be. The lighter the particles, the upper it will be. So we started this electricity and we are putting basically this blood specimen on a gel, okay? After starting the electricity, these portions start moving up. Going up, until they reach their numbers. They will show you something like this in your actual exam. So you will be taking a look at, this is actually a good one. So this is even better. Okay, so they will show you something like this and be like, well, what do you think? What does the patient have? If you speak about sickle cell disease, mainly you have hemoglobin S, not hemoglobin A. In a normal adult, you are supposed to have hemoglobin A, that's it. In an infant, you have both hemoglobin A and hemoglobin F, as you can see. So hemoglobin A and hemoglobin F in a newborn. In case of sickle cell disease, you only have hemoglobin S, okay? So, and in case of sickle cell triad, you have some normal hemoglobin A and some pathological hemoglobin S, which is here, hemoglobin S. Can you tell me, please, which one of these two will have severe symptoms, disease or trait? Keep in mind that the disease, has no normal hemoglobin. The trait has some normal hemoglobin. So the disease will be much more worse. That is correct. Okay, so let me just send you this. Okay, so moving back to here, this is the difference between sickle cell disease and the trait. So there is one more point I want to clear up for you guys regarding this electrophoresis. We can do it for so many pathologies. The main idea of it that it separates the different proteins according to their weight, okay? According to their weight, it separates different proteins. So going back here, we have something called acute pyelonephritis. Can you tell me what is the most common cause of acute pyelonephritis? What is the most common cause of acute pyelonephritis? Bacteria. I'm asking about the microorganism. Which bacteria? E. coli. Yeah, good. So is UTI an ascending infection or a descending infection? Yes, it's ascending, which means it can start from any portion in your urinary tract and go up. Okay, for example, it can start in your bladder and go to your ureter and then goes up to your bulbocalycial system and to your kidney. By the way, speaking about the bulbocalycial system, I have noticed that anytime I say bulbocalycial system, people get confused. So I even cannot write it correctly. So what is the bulbocalycial system? The bulbocalycial system is consistent of two portions. You have your calyx, so we call this a calyx, we call this a calyx. You have minor calyxes and you have major calyxes, and they drain all to one big renal pelvis, and that drains into the ureter. Urologists notice that it's really painful to keep saying, well, your minor calyxes, major calyxes, and renal pelvis. So they started using the word bulbocalycial system, bulbocalycial system. So basically it's all at once. When it is all at once, we call it bulbocalycial system. Okay, in case of acute pyelonephritis, will you have cast in the urine or not? I'm sorry, I'm using like this pathology to review all of pathology. You will, it's actually possible to have casts if it affects which portion of the kidney? Yes, the tubules. Excellent. If it affects the tubules. If we speak about cystitis, on the other hand, which is an inflammation of the bladder, urinary bladder, will you have casts? Somebody already answered. Okay. Yes, that is correct. You will not have casts. That is completely correct. Okay, so one more thing about this patient with renal papillary necrosis. Guys, what type of necrosis do you think they have? Is it coagulative, liquefactive, caseous? Which one do you think it is? It cannot be liquefactive. Liquefactive only affects the three organs. Do you remember what the three pathologies can lead to liquefactive? It's, in this case, it's coagulative. Renal papillary necrosis is coagulative. Please write a note about that. So the liquefactive, it will be three organs, three pathologies actually. The first one is the brain, in which the microglial cells make you what? Make enzymes that lead to creation of the liquefactive necrosis. The other one, somebody write the other one, please. The other one is an abscess, okay? The other one is an abscess. And the third one and the last one is intrapancreatic necrosis. Intrapancreatic necrosis. If it was peripancreatic necrosis, peripancreatic, it will be what? So, it will be what type? Fat necrosis. But if it was intra, it will be which type of necrosis? It will be liquefactive. Okay? So, here we go, something like, it goes something like this. In case of renal papillary necrosis, basically anything that leads to ischemia of the papilla, it will lead to renal papillary necrosis. And there will be sloughing of the papilla, and when this sloughing off occur, you will have urethral obstruction, and you can even have a scarring of that area. Well, so do you think this pathology is painful or painless if all of that happened? It's really painful, really painful. And guys, I just told you that what happens in this pathology, that basically that after the sloughing off occurs, it will block the system, yes? So this blockage of the system will be something like this. So you will have, let's say this is your tubule, and then you will have an obstruction here. Why? Because there was a sloughing off of some cells towards this area, and yeah, they blocked it. So after a blockage, will the pain be colicky or continuous? What do you think? Colicky pain is a pain that comes and go. Continuous pain that is a form of persistent pain. And I will tell you a trick that you should never forget about. Every single time you hear the word blockade, you will directly have to think about what? Blockade, colicky. That's it. So if I ask you, well, someone had renal stone, kidney stone, it's a block. So you think the pain will be colicky or continuous? Done. If we speak, the patient had the stone in his gallbladder, which leading to blockage of the cystic duct. Colicky or continuous? Colicky. Excellent. The patient has a fecalith inside of his appendix. It will be colicky or continuous? Colicky, obstruction. Every time you hear the word blockade, obstruction, you go with colicky. Okay. So the patient will have also hematuria, which can be seen with your own eyes. So it's kind of really bad. And these poor patients also have the systemic symptoms, the fever and the chills. And they can even develop acute renal failure. So speaking about these patients, it's highly associated with NSAIDs and diabetes mellitus as well. Guys, about NSAIDs, why do you think NSAIDs lead to renal papillary necrosis? What portion of the kidney does NSAID work at? Afferent arteriole. Afferent arteriole. So if we draw a kidney here, this is the afferent arteriole, this is your glomerulus, and this is your efferent arteriole. So aspirin will work here. It will work A aspirin. So NSAIDs, A for aspirin. So it will lead to vasoconstriction of your afferent arteriole. When it blocks your afferent arteriole, what is going to happen to your renal plasma flow? Go down. Excellent. So it will go down. It will go really, really down. That your, after efferent arteriole, what comes? We have the peritubular capillary. So these will be starving for blood. So there will be ischemia of the kidney. And which portion of the kidney is highly susceptible to ischemia? I know that it's the BCT and the ascending lobe of Henle, but I want you to tell me exactly, are these portions in the medulla or in the cortex? In the medulla. Excellent. Guys, I noticed someone, like I was having a private class with somebody and they had a problem with the BCT. When I told them like the BCT, proximal convoluted tubule, is the medullary portion of it, it's affected, he could not understand that it's located in the medulla. He was like, no, but you told me that the cortex is the upper portion, so it's the portion containing the, basically the proximal tubule. He's correct and wrong. Why? Because the proximal tubule consists of two portions. It has a convoluted portion, which is located in the cortex. And it has a straight portion. This is the straight portion is located where? In the medulla. So you must know, you must understand that there is two portions of your nephron. So one portion in the cortex, which is the convoluted part, while the straight part is mostly inside of your what? Inside of your medulla. And the one that is highly susceptible to ischemia, it will be the what? Which portion? The straight portion. Okay, so let me send you this picture to understand. Can you repeat the symptoms quickly? The symptoms of which pathology? Are you asking about renal papillary necrosis? Yes, okay, good. So in case of renal papillary necrosis, the patient will have really bad flank pain, and it's due to an obstruction, as we said, that the tubules had a sloughing off of the cells inside of them, which led to blockage of the tubule. If you have a blockage of the tubule, the pain will be continuous or colicky. Colicky pain, exactly. The next thing, do you think a pathology affecting the kidney basically will have systemic symptoms or, well, not systemic symptoms? Systemic symptoms, exactly. The symptoms will be systemic. It will be affecting all over the body. Okay, good. And just a second, I need just to check one thing. Okay, so the next thing, it goes something like this. It goes something like this. We have the next symptoms is systemic symptoms. So if systemic symptoms, they include fever, they include chills, and they include other stuff. For example, this patient will also have what? They will have blood in their urine. Will it be microscopic or macroscopic? The answer is both. You will be able to see it with your eyes, and in the same time you will be able to see it in histology. Okay, so it's both. And the next thing, it goes something like this. This patient with the renal papillary necrosis, if we spoke that the aspirin blocked this area, so the perfusion to the peritubular capillary will be much less. If the perfusion to the peritubular capillary is much less, the patient will be suffering from ischemia. To which portion? The medulla, leading to what? Renal papillary necrosis. Okay? So, next one. So that was renal papillary necrosis. Remember, just it's really painful, and they like to show you this picture. So let me show you renal papillary necrosis. Remember, it's an coagulative form of necrosis, and the way you take a look at, I will tell you the trick about it. So they will show you something like this, and it's a mess. As you can see, it's hard to detect. What is this? They will tell you it's a kidney. So the moment you see it, you need to search for the calyces. Here is the calyces, yes? So then you are looking for what? You are looking for dark color. So paleness, you can see here. This is the paleness, this is the paleness, and this is the paleness. So this is the papilla of the kidney. So this is papillary necrosis. There is even a better picture here, but this one is bad. The whole pyramid is affected. So you can see here is your calyces. They are going to your pyramid, and the pyramid is like all black, which is basically mean death. Okay, so the next thing you must know. Okay, there was one more picture I was interested. Oh yeah, here it is. Okay, so let's go. No, okay, this one. So, so it's this one also. I never seen it asking about this one, but just for the sake of completeness, this is your papilla coming here, and this is what? The slough of epithelium inside of your tubules that leading to the blockage. Okay, so the next thing here we have consequences of renal failure. Okay, we spoke about different pathology leading to renal failure. Before speaking about the consequences, I just want to make sure about one thing. Speaking about the intrinsic renal failure, I want to make sure you got the FENA principle. So in a patient with an intrinsic renal failure, what will happen to the reabsorptive function in the kidney? Decrease. Good, it will be decreased. So what is going to happen to the fractional excretion of sodium? Fractional excretion of sodium. It will be increased. Somebody said decrease, so really quick. If your kidney cannot reabsorb the substance, it cannot get the substance back to your blood, it will be more in the urine. So the amount that will be excreted compared to the amount that is filtered will be quite higher now. So that leads to increased FeNA, which is a fractional excretion of sodium. You must know these numbers. If it's more than 2, it means it's increased. If it's less than 1, it means that it's decreased. Okay. So moving on, we have consequences of renal failure. It's a decline in renal filtration, can lead to excess retained nitrogenous waste product. Okay, we agree on that. So what is nitrogenous waste product? Can you give me an example, guys, of nitrogenous waste product? A product that has a lot of nitrogen in it. Urea, excellent, good. So, and electrolyte disturbance. Let's try to understand how this process occurs exactly. So, starting with the metabolic acidosis. The kidney is dysfunctional. It's destroyed, totally destroyed. So this metabolic acidosis happens with two mechanisms you need to know. The first mechanism is regarding to the aldosterone. Forget about what we are speaking about now. Can someone please tell me where aldosterone function? Where does aldosterone work? At the collecting duct. Can someone tell me exactly which cells in the collecting duct? For the person who said DCT, man, you studied deeply. He's actually correct because your DCT is two portion. It has a proximal portion and a distal portion. So the proximal portion of your DCT does not get affected by aldosterone, but your distal portion of your DCT get affected by aldosterone because it also have like principal cells and intercalated cells. That is correct. Okay, alpha intercalated cells. Okay, so speaking about aldosterone, what does aldosterone do with the sodium? Does it get it into the body or out from the body? Okay, with the sodium into the body. What about potassium? Outside of the body. Well, so far so good. You are answering correctly. But let's imagine that the patient has kidney failure. So all of these cells will be destroyed. All of these cells in this page will be destroyed, including these cells. That means that the principal cells and the alpha intercalated cells will be destroyed. If they are destroyed, can you excrete potassium anymore? Because remember, potassium used to be excreted here. So what will happen to your potassium level? Will become high or low? High. Yes, the potassium will accumulate inside of your body. So this is the first mechanism. Okay, potassium more in your body, you have hyperkalemia. We agree on that. What does potassium love? What is the best friend for potassium? Hydrogen. And if you have a lot of hydrogen, what will happen to you? Acidosis or alkalosis? Acidosis. So the first mechanism in which you have metabolic acidosis because of decreased responsiveness of the aldosterone. The second thing you must know about is something regarding the BCT. So if you look at the proximal convoluted tubule, we had a really long process here. And it goes something like this. Some substance were filtered into the urine. Remember, the tubule is in this side, and in this side you have the blood. So some substance was filtered into your tubules. And after it was filtered into your tubules, this substance is bicarbonate. Bicarbonate is an acid or a base? Come on. Acid or base, bicarbonate. It's a base, alkaline. Good. So this bicarbonate was throwing into the urine and it was going out. When hydrogen met him and he was like, well, wanna come inside? And he was like, yeah, sure. How to do that? He was like, look, you cannot come inside because you are too big. He was like, okay, so how can I come inside? Can you give me like an alternative way so I can come inside? And he was like, yeah, sure. So we can make bicarbonic acid from each other, and then we will call our friend, a smuggler, called carbonic anhydrase. That carbonic anhydrase will split us into H2O and CO2, which are really small particles that can go inside. And after we go inside, we can reform the bicarbonic acid with the help of our smuggler, and that will make us inside, me and you. And you can be reabsorbed into the body, which will lead to increased bicarbonate inside of the body, which lead to an alkaline state inside of the body. While me, I don't like this body, so I'm going to do the whole process again. So he was like, okay, that sounds good. Thank you. What is the catch? I was like, no catch. I was like, excellent. Okay, so what about if we destroy somebody with renal failure? He has destruction of this whole cell. It's not working. Will he be able to reabsorb bicarb? Yes or no? From this portion of the kidney, if it's destroyed. He will not be able to reabsorb bicarb. If you cannot reabsorb bicarb into your body, will you have metabolic acidosis or metabolic alkalosis? Metabolic acidosis, you cannot reabsorb alkaline. So you will have acidosis. So this is the second mechanism in which you will have basically what? Metabolic acidosis as a consequence of acute renal failure. Okay, good. So let's speak about the next one. So as you can see, metabolic acidosis, the next one is dyslipidemia, especially increased triglyceride. Well, I hope you guys remember about something called lipoprotein. This lipoprotein can be lost in the urine, and if in case of which disease, if you can remind me. Which disease can lead to loss of proteins inside of the urine, including lipoproteins? Minimal change disease is a type. Okay, liver disease, it could be, but we are speaking about the kidney. Which disease of the kidney? Nephrotic syndrome. Exactly, it's the nephrotic syndrome. So in case of the nephrotic syndrome, it becomes dysfunctional. So you can have a lot of excretion of this lipoprotein. Fanconi syndrome with destruction of the proximal convoluted tubule will lead to reduction of reabsorption of the amino acid, which actually true, will lead to decreased amount of amino acid, decreased proteins, and thus decreased lipoproteins, and thus you will have also dyslipidemia. Downregulation of the lipoprotein lead to dyslipidemia. So the next one is hypotassium. Because of what? It was dysfunction of which hormone? Can somebody write it, please? Yes, aldosterone was not able to work in its receptor, as we saw. Okay, uremia, because an ability to filter to filter the urea outside of the body. So now will come the student and be like, man, you lied at me. Okay, let me re-explain the dyslipidemia one more time. So there is something called lipoproteins. We will speak about them in biochem actually, but just in general, there is particles that are called lipoprotein, which help in the transportation of the what? Of the fat, okay? They get fat molecules inside of them and move them from point A to point B. They move them back to the liver where they can be destroyed and all of the good stuff, destroying the lipids inside of the liver. Why the liver can destroy the lipid? Because it has a process called beta oxidation that we'll speak about in biochemistry. But in general, your body must have lipoprotein to do this process. If he does not have that lipoprotein, he cannot do this process. So if you have nephrotic syndrome, you are losing what? Proteins, including whom? Lipoproteins. No lipoproteins, dyslipidemia. Why? Because you are unable to take the fat to your liver to get oxidized and destroyed. So it will happen what? Dyslipidemia. Okay, now we speak about uremia. Now the person will come to me and be like, you lied at me. You tricked me. You remember when you told me in pre-renal azotemia, we had more reabsorption of urea, and now you are telling me that basically not this one. Basically in this one, you are telling me that we have uremia. How come we have uremia? And in case of pre-renal azotemia, we had more urea reabsorption. Well, you are like, okay, that actually lead to uremia. But before we speak about that, we need to know where urea is made to know all of the life cycle of it. Guys, what is urea made? Okay, liver. Good. That's a tricky question. Everybody says kidney, it's wrong. It's the liver. And it's made out of from what? Ammonia. And now comes the tricky question. Where ammonia is, what makes ammonia in the first place? What makes ammonia? It's a byproduct, but byproduct of what? For proteins and amino acid. Excellent. So proteins and amino acid, byproduct is ammonia. Yeah, meat. Actually, this is actually important. If we say that you just ate a big chunk of steak today for dinner, what happens inside of your body? If you get this idea inside of your brain, it's kind of difficult to forget. So you will have a piece of meat. Meat consists of what? Cells. Cells have what? They have Proteins, they have a nucleus. Well, from the cells proteins, you will get what? Ammonia, yes? Proteins become ammonia. Ammonia becomes urea. Urea goes outside, yes? But from the nucleus, other substance will come. From the nucleus, you will have what coming? Let me make it different color. Green is good. Okay, from the nucleus, what will come? DNA, yes, a nucleic acid, exactly. This DNA will be converted into what? Guanosine and guanine and pyrimidine and purines. Basically, it will be converted into nucleotides. So these nucleotides will then be converted by which process? Our amigo here. At the first pages of biochem that we'll speak about pretty soon, I hope. So here we have this nucleic acid becoming GMP, guanosine, guanine, and finally hypoxanthine, xanthine, and uric acid. So after you ate that piece of meat, you have increase of urea in your system, and also you have increase of uric acid. So yeah, think about this whole process next time you eat a steak. So moving on, we go to renal, and come on, why it's not zooming out? Okay, so far we spoke about some consequences. Now we have uremia because we are unable to filter the urea outside of the body. Okay, so urea will stuck in. And then it comes one more thing you must know about. There will be sodium and H2O retention inside of your body. Because why? Because you are unable to filter them out. That will lead to basically a volume overload of your body. And if your volume inside of your body increases, what will happen to the preload? Up, afterload. Up, it will be up as well. It will be up as well. There is more blood inside of the vessels, making it harder for the heart to push against that increased volume. Okay, so that can lead to pulmonary edema and hypertension. And now I have this simple question. If someone has kidney failure, when the edema will be more prominent? Is it early in the morning or after a long day at work? Morning. Why? Long time no pee. I love that answer. Exactly. So all night he did not go to the bathroom, so there was accumulation of fluid inside of his body, and there was a lot of sodium retention, H2O retention. He become puffy. Will the edema be more in the face or the legs? It will be in the face. That's correct. Okay, the next thing is growth retardation and developmental delay. Of course, they have a freaking kidney failure. I will speak about how it even can destroy your bone pretty soon. Also, erythrocyte deficiency, erythropoietin deficiency. Well, this is actually really important. There is a substance called erythropoietin. It's basically a hormone. That erythropoietin is made inside of your kidney. You must know exactly where inside of your kidney it's made. It's not enough to say kidney. You will never get a question that tells you where erythropoietin is made and the answer is kidney. You need to know exactly where it's made. And if you get that question, it's made by the interstitial cells in the pretubular capillary. Please know it. Interstitial cells of a pretubular capillary. They love to ask about that one. Okay, moving on, we have... okay, come on. Yes, we have renal osteodystrophy. Well, you are like, why? Well, we have which vitamin is made inside of your kidney? Excellent, that's vitamin D. Which vitamin D? Was it 125, 25, or which type of vitamin D? 125, excellent, 125, because of the presence of 1-alpha hydroxylase inside of the kidney. So you must also know that it's located in the epithelium of the BCT, the 1-alpha hydroxylase, okay? So renal osteodystrophy, it means that when your kidney is dysfunctional, you will have reduction of the vitamin D. That reduction of the vitamin D will lead to less calcium. Less calcium will lead to what? Basically, less deposition of calcium inside of the inside of the bone. That, yes, and that will lead to less calcium inside of the bone. Less calcium inside of the bone will lead to what? Basically osteomalacia and basically bone destruction. So yeah, you see, it's a long process, but basically ends up with leading to what happens after that? If you have a low calcium level, one hormone will be activated, which is PTH. Yes, parathyroid hormone. PTH will be activated, and you will have high amount of PTH while you have a low amount of calcium. We call that secondary hyperparathyroidism. When that happens for a really, really long amount of time, your body will be like, oh, well, okay, we have low calcium, we have high PTH. So mistakenly, the body will keep secreting a lot of hyperparathyroidism regardless of the level of calcium. He does not care about the level of calcium anymore. When that happens, we call it tertiary hyperparathyroidism. We'll speak about this pathology much more in endocrinology, but this is the general principles of it. So two forms of renal failure exist, acute and chronic. So the acute one, for example, acute tubular necrosis. And the chronic one, it could be like due to hypertension, diabetes mellitus, and congenital anomalies. Which one? The osteodystrophy of renal osteodystrophy as a consequence of renal failure? Oh, don't worry about it. See, there is a whole topic where I'm going to explain about it. So just wait for it for a second. We'll finish this and then we'll explain it deeply. So, okay, two forms of renal failure exist, acute and chronic. Acute one can be like in case of acute tubular necrosis, while the chronic one can be due to hypertension, diabetes mellitus, congenital anomalies. The question does not come like that. The question comes and tell you which portion of the kidney will be affected first in case of diabetes mellitus. Which portion of the kidney will be affected first in the diabetes mellitus? The answer goes something like this. Is it your BCT? Is it your efferent arteriole? Is it your afferent arteriole? Or is it your glomerulus? What do you think? What is the first portion to be affected by diabetes mellitus? No, actually it's the efferent arteriole. Why this is super important? Why I'm telling you about this pathology? Because there is a drug that helps prevent that damage. So if we speak about, this is your afferent arteriole. This is your glomerulus. Yeah? This is your efferent arteriole. I told you that diabetes mellitus, not eflozicine, no. I told you that diabetes mellitus begin with destruction of what? The efferent arteriole. Basically sclerosis and non-enzymatic glycylation of the efferent arteriole. Okay, your efferent arteriole is becoming more tight, basically, more constricted now because of this process. What is going to happen to your GFR? What will happen to the GFR initially? It will be up, exactly. So you're like, wait a second, no, GFR in diabetes will be low. I'm like, wait for it. Initially, it becomes higher. So initially, let's imagine that this is your GFR. Initially, it will go up, and then it will go down. Much worse than it was. So again, it's up, then it goes down. Here, it was the norm. Initially, because of the blockage here, what happened to the GFR? It increased significantly. But when it increased significantly, the amount of filtration, what will happen to it? What will happen to the filtration fraction in this case? Increase GFR. If I increase the GFR, filtration fraction will go up, obviously. So more filtration constantly happening through the glomerulus will lead to sclerosis of the glomerulus. So after the GFR has increased, when the sclerosis of the glomerulus happen because of the constantly high pressure inside of it, will lead to decrease in the GFR and basically precipitate to renal failure. In the US, renal failure is most commonly secondary to diabetes mellitus. Diabetes mellitus is the most common cause of renal failure and patient who request renal transplant in the US. Okay, so how can I prevent this whole process from happening? What was the most initial pathology? It was, yes, I can. Well, let me do it like this. I will not re-explain it. I will make the other student re-explain it. Can you tell me, please, what is the first portion of the kidney to be affected by diabetes mellitus? Efferent arteriole. Efferent arteriole. Well, the logical question actually will be, why efferent arteriole, not afferent arteriole? It's logical. Well, the speed of the flow. In the future, actually this is kind of a step 2 material, but anyway, you will see that the speed of the flow through the efferent arteriole, you have just undergone what? A massive pressure of your aorta. That's really hard push, yeah? Then you moved through many the glomeruli. Actually, it's not just one vessels, they have millions of minor vessels, yeah? And after you have moved through these vessels and you reach your efferent arteriole, the flow becomes slower. So the glycolation process can happen much more easier at this point. When this glycolation process at the efferent arteriole happens, it will make the efferent arteriole much more tight. When your efferent arteriole is much more tight, what is going to happen to your GFR? It will be high. It will go up. So when your GFI will go up, what happens to your filtration fraction? Goes up as well. Excellent. So your filtration fraction is up. That will lead to what in your hydrostatic pressure of your glomerular capillary? So what happens to the hydrostatic pressure of the glomerular capillary? It will be increased as well. So if that will be increased, there will be more sclerosis process, which is hardening of your glomerulus, which will destroy your glomerulus. So initially, destruction of the efferent arteriole increased your GFR. But after sometimes the glomerulus started to get destroyed himself. That started to decrease the GFR, okay? So you want to prevent the pathology from its beginning. So which substance lead to constriction of the efferent arteriole? Except, forget about diabetes. Which substance lead to constriction, I did not say dilatation, constriction of the efferent arteriole? It is angiotensin 2. Yes, angiotensin 2. It leads to vasoconstriction. How can, so it leads to vasoconstriction, the same thing that diabetes does. So if I want to reduce the problem that diabetes did, I must decrease the angiotensin 2. Which drug can decrease the angiotensin 2 function? ACE inhibitor and ARBs inhibitor. Yes, why? Because there was like this process we spoke about in the RAS system. Angiotensin 1 was converted to angiotensin 2. Angiotensin 1 was converted to angiotensin 2 using ACE. So if the ACE is inhibited, boom, boom, the angiotensin 2 will be out. So you will have vasodilatation. If you have vasodilatation in case of kidney, if someone has diabetes, well, his GFR initially is like this, yeah? He started having diabetes, so GFR started to increase. You give him an ACE inhibitor. ACE inhibitor will dilate your efferent arteriole. What happens to GFR if you dilate the efferent arteriole? It goes down. So it goes down and stay like this in the normal range. So if it stays at the normal range, perfect. It will not go down. You saved his life by giving him ACE inhibitor. This is why, if you remember, like when I was speaking with you about cardiology, guys, in cardiology, I was telling you about different ways that different medication we give for patient with different pathologies of their heart, hypertension basically, different management of hypertension. One of the management I mentioned is hypertension with diabetes mellitus. We give them first-line therapy, ACE inhibitor and ARBs inhibitor. Yes? Because, why? ACE inhibitor and ARBs inhibitor protect against diabetic nephropathy, and now you understand why. Because they dilate the efferent arteriole. Two birds in one stone. Exactly. Good. Actually, this is like, I will keep telling you about tricks like this because it's both asked in the exam and you will see it in your real life, you know. So, okay, that took a little bit more time than expected. Next, we have incremental reduction of GFR defines the stage of chronic kidney disease. So if you remember, the GFR and the creatinine relationship is inverse, which means that if the patient has a lower creatinine level, he's going to have GFR, which is good. A high GFR means the kidney is functioning perfectly. A low creatinine means that the kidney functioning perfectly. So a patient with both low creatinine and high GFR is the top. See, he's 180 GFR and 0.2 creatinine. So his kidney are functioning perfectly. While the patient with 40 GFR and 2.4 creatinine, that means his kidney sucks. She's dying. Okay, so the worse your GFR becomes, the worse your kidney function becomes. That's what they are writing. Normal phosphate level are maintained during early stages of chronic kidney disease due to making of substance called fibroblast growth factor 23. I know it's annoying that you keep seeing this weird name substances, but there is a substance that is made in the kidney. It will be lovely if someone can tell me what exactly in the kidney. And you know, if you don't know anything about the kidney, you write what? Which area is the most active area in your kidney? Exactly, BCT, excellent. So it's made there. And that fibroblast growth factor promotes the phosphate excretion. Why? Because normally the phosphate inside of your kidney, it's getting, well, it gets out. But this patient has chronic kidney disease, so his kidney is unable to excrete the phosphate out. So fibroblast growth factor step in, and he removes the phosphate from your circulation. Next thing is uremia. Uremia is syndrome resulting from high serum urea. It can present with nausea, anorexia, and encephalopathy seen with asterixis. Which other condition can lead to asterixis, guys? Which other condition can lead to asterixis? Asterixis is basically a typical hand movement, which is like a tremor-like symptoms. Actually, let's take a quick look at it, at a video of it. It's hand movement, basically, in which when you see it, it's like a flapping tremor. You tell the patient to do this.
This video will introduce you.
So you tell the patient, okay, can you put your hands in front of yourself and flex them backward? See it? And now look what happened. This is cool. They are vibrating, but this is bad, actually. Oh, yeah, this one. You push against his hand, and after you push against his hand, he's fake. He's fake. He's super fake. This is not correct. Okay. Let's see this one. See, you have just to give it a little push against his hand. And you will see, he will have really hard time correcting it. See, they are vibrating. And if you push his hand a little bit, they will be vibrating really, really, really bad. And the question comes, why? Why these patients are suffering from this? Well, because there's something inside of your brain called basal ganglia, okay? And when this basal ganglia is basically damaged, it can lead to this asterixis, okay? And it gets damaged because of urea and ammonia, okay? So the other condition is hyperammonemia. Okay, so increase in urea, we spoke about it in CVS. We spoke about it leads to pericarditis. And I told you, pericarditis normally is treated by NSAIDs, except in one case, uremia. In case of uremia, do not give NSAIDs. What do you have to do? In case of uremia, instead of the NSAIDs, you must give dialysis. You must remove that urea from the body, so you give dialysis. The next thing is platelet dysfunction. Well, you have the patient and he has kidney, actually this is a really common question. They give you a patient with really high creatinine level, 3 or 4. And after that, they tell you, well, this patient is fine, but now he's bleeding from every single orifice he has. He's bleeding from his nose, she's having menstrual problem, all of that stuff. And then they mentioned that her platelet count is normal. Her BT and BTT, prothrombin time, is normal. Her BTT is also normal. Everything is normal in this patient. And the only thing that will be elevated is the bleeding time. Remember, bleeding time is a marker for a platelet. So bleeding time will be high. And after the bleeding time mentioned that it's high, they tell you the twist. Platelet count is normal. So it must not be a quantitative dysfunction of the platelet. It's a qualitative dysfunction of the platelet, which could be due to uremia. Basically, this urea particle binds to the platelet and prevented it from exerting its function and binding to the von Willebrand factor and binding to each other, which lead to the platelet just being there but not being functional, which basically lead to a qualitative dysfunction of your platelet. And the management is with dialysis. Okay, good. So that was a good brief explanation of all of these consequences of kidney failure. Now we'll take a small break, come back, speak about the rest of the consequences. So see you guys in 10 minutes.